Opioid use disorder or opioid addiction can be scary. It can be scary to the person going through it, scary to friends and family to watch, but it is a treatable disorder and is a recognized medical disorder. Opioid use disorder develops as the brain remodels over time and adapts to very high levels of opioids with subsequent increases in dopamine levels in the brain. The reality is that although opioids have taken control over a person's life, we can use other medications to get it back. Now, the data shows overwhelmingly that people with opioid use disorder are best benefited by something called a biopsychosocial spiritual approach to treatment. And this treatment approach is often best provided through multimodal therapy and a variety of services engaged. That includes a provider who's willing to offer the biological treatment, which is typically something called MAUD, or medication for opioid use disorder. Now, these medications are typically either buprenorphine, which can be provided by your doctor in a clinic setting, methadone, which is typically prescribed through an opioid treatment program, which is federally regulated, or naltrexone, another prescribed medication. Together, these medicines provide a stabilizing effect on the host opioid defect problem. Now, it's important to understand both buprenorphine and methadone are opioids themselves. And you might be wondering, why on earth, if I have an opioid use disorder, would I use another opioid to get myself out of it? As strange as it seems, the reality is that the science is very much intact. Drugs like methadone and buprenorphine are important to opioid use disorder because, like opioids that we take for illegitimate purposes or take illicitly, these opioids still bind to the opioid receptor. They still lead to activation of the opioid receptor, but they do not lead to the high highs that people experience with the other drugs they've been abusing. By binding to these receptors, people avoid the withdrawals that they often experience on opioids when they wear off, and they avoid the highs that they experience when they take them. Over time, with use of these medications, it allows the brain to heal. The length of therapy in opioid use disorder for these medications is very much dependent on the person. Much of our data suggests that longer-term use of these medicines is better, but certainly have a conversation with your provider about your goals. Some patients prefer to be completely off of them, and there might be a timeline when it's appropriate to start tapering. Again, discussions are important. Naltrexone is a bit different than the other two medicines. It binds to the receptor that opioids bind to, but it does not activate that receptor. This can lead to rather profound withdrawals in some patients, and so it's important if you're actively using opioids to select maybe an agent that is different. So it's important to talk with your provider about whether use of naltrexone is appropriate for you. These are often good medications in people that have no interest in being on opioids themselves for long periods of time. All of these medicines should be used in combination with the psychosocial spiritual interventions, and that's licensed counseling, that's ensuring that there's family dynamic issues that are addressed, that's dealing with any bipolar, schizophrenia, depression, anxiety, or other mental health disorders that are concurrent. It also means addressing spiritual issues if that's a big part of your life. Together with biopsychosocial spiritual interventions, a person becomes whole as a person, not just as a specific part of what their problem is. And we recognize that with opioid use disorder, the best outcomes are those where a person is treated as a whole. Talk with your provider today about what options are available to you, and make sure that you work with friends and family to find the right treatment approach. What if we are the generation that ends this opioid epidemic for good? Opioid-related overdose deaths are now the #1 cause of death in adults under age 45. Their influence has been so great, they're even reducing the American life expectancy. These trends have us fearing the worst, and as a result, we begin to view opioids as the enemy. The drugs that we've long trusted to help kill pain are now killing us, and with this, we fear what they'll take from us when we take them. But what if opioids aren't the enemy? What if our misunderstandings of them was? What if we truly took the time to understand pain and addiction from the perspective of those dealing with it? Would our stories have happier endings? You see, the opioid epidemic is always personal. I lost my own nephew, just 24 years old, after sustaining a head injury in a skiing accident, unable to live with the pain anymore and unable to navigate the medical system, to suicide. You see, the opioid epidemic is a story about all of us. It's about the people we love, the people we've lost, and the people we fear losing. Medical providers can't prescribe us out of the opioid crisis. Government agencies can't regulate us out of it. Drug treatment programs can't counsel us out of it. It is time that we start to fight the myths about opioids instead of the drugs themselves. What would the world look like if we were equipped with the information on how to use opioids wisely, store them safely, avoid their risks, and reverse their problems? It's time we turn our attention away from the battle against opioids and instead put our focus on the people who may truly benefit from their use or those who are facing their consequences. What if we all work together? Hope is in sight, and this crisis is ours to end. This can be the generation to do it. That ending must include you.